Another mastermind hit.
Well, good morning. I'm Mary Jane Borden, and so it's great to be here. Thank you to Menelec and to everyone who planned this lovely day. I'm hoping we're going to have some legislators here because that's who we really want to talk to. And if you're some are here, and I'm just sorry I don't recognize you. And I think we're going to have a lot to teach you and let you know about why we need to have greater freedoms, if you will, for cannabis in Ohio and federally as well. So again, my name is Mary Jane Borden. As I said, I write a monthly column called Mary Jane's Guide for the Columbus Free Press. And Mary Jane, as I said, is my real name. I actually was born with this name, so it's been with me all my life. So I write a column, as I said, called Mary Jane's Guide based upon my name. And I guess the 20 to 40 years that I've been in cannabis reform, depending upon how you count those years. And so I thought I'd start out, what I'm going to do is I wrote this article for the Columbus Free Press, and it just posted yesterday. And it's Mary Jane's Guide to Breast Cancer and Cannabis. It's a Q&A, a question and answer piece. And it just posted to the Free Press yesterday, so you can read it there. And it's a Free Press, I think, I put some copies over on the table, and I also put some copies of some bill analyses that I've done for HB 382, for the initiative, and also for Senator Schuman's draft of proposed federal legislation that has it. And of course, it's probably all outdated now because these things change quickly over time as they progress through the system. And we don't actually have anything from the federal government yet, so we don't really know what the end result, if any, there will be from the feds this year. But my most recent article, as I said, I covered breast cancer and cannabis. Now I thought, rather than starting at the end, I'd start at the beginning. Or start at the beginning, I start at the end. I'm making sense right now. Okay, so what qualifies me to talk about cancer? Okay, what qualifies me? I'm not a medical practitioner. In fact, I don't have much medical education. All right, so what qualifies me? Well, first of all, I don't know if this sounds right, but I have an MBA in finance. And what that taught me was how to analyze information, pull out data and things like that. So if you're familiar with my work, you'll see a lot of that infused in it. And so the next thing that qualifies me, and I shun sometimes to say this, it's embarrassing, but I spent 9 years with Big Pharma. I was at Big Pharma. These are the big pharmaceutical company that was the leading marketer in its time of cancer chemotherapy agents. And my job was to analyze them and report to management on various things about them. So therein, I think after 9 years in that industry, I think I know chemotherapy, okay? So what's the other thing I think about my experience with Adria Laboratories? If you don't know what Adria is, if you go up off 161 in Dublin, that's where the Ohio University Medical School is. In that time, before that, that was Adria Laboratories. And so the other thing I did was I was a project manager on a database of over 30,000 cancer patients, and that listed all of their medications and all their business they had to the doctors. So as being a project manager on that database, I really got delved into what cancer patients were going through. And I should add that the Adria's primary product, and I'd look at this as a product sort of way. May sound counterintuitive to do this, but neither of the pharmaceutical companies, we're all products, we're all widgets. We'll get to that in a minute. All right, so the final thing, okay, I'm a medical cannabis activist. Well, you know what? I was going through my old normal box. Everybody has their normal box, right? So I was going through my normal box, a few days ago, and I was looking through all this stuff. I found a letter from National Normal to me, dated 1982, welcoming me to marijuana advocacy. Okay, I can prove it. So, I say 20 to 40 years, I got proof. And then finally, the other fun thing I think that qualifies me to talk about cancer is that I am a cancer patient. Last year at this time, I was diagnosed with what's called triple negative, grade 3 breast cancer. And that's about the worst thing you can have. So lucky me, I get the worst thing you can have. And this is kind of a story about how I dealt with that diagnosis and why I'm standing here with you today. And like I said, you can read this on more about it if you go to the Free Press website. All this stuff is linked, okay? And in fact, when I write stuff for the Free Press, I link everything. That's how I cite things. Rather than footnotes, I cite them by linking to them. So you'll see my work is heavily linked. Now, what I thought I'd do, now that you know about me and that I have the authority, if you will, a moral authority, nothing else, to talk about breast cancer, I thought I'd run through this because this is Breast Cancer Month. This has been nationally declared Breast Cancer Month by the American Cancer Society and the National Breast Cancer Foundation. And note that its roots lie in the pharmaceutical industry because it's now AstraZeneca was heavily involved in the founding of Breast Cancer Awareness Month. That kind of makes sense. And so we always see in the Breast Cancer Awareness Month, the little pink ribbons, and I think there's an interesting story there because it grew up, what are we but protesters, in our own individual ways. So this grew out of the little pink ribbons, grew out actually of a protest of a woman who had her family died of cancer and was upset because very little of the budget for breast cancer is attributable to prevention. And she felt that was her way of making a statement. Boy, it made a big statement because these pink ribbon campaigns are so prevalent now. And they've been picked up by the Susan Komen Foundation, who is a major funder of clinical trials at major universities. And it's also been picked up by I guess they said the Breast Cancer Research Foundation. So let's a little bit of the elements here. I'm sure you guys know this. This is how the article works. I'm just going to run through them kind of quickly. And so what's breast cancer? And I quote you from the National Cancer Institute. It's a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. That's just kind of basic definition. And when I do these articles, I do a tremendous amount of research. I'll probably access 500 sites maybe easily. Yes, I use the internet. And so what I learned is that we all contain cancer cells within us at some point, and that cancer cells are normal. When things go awry, they actually multiply much faster than they should. So the idea that somehow every one of us in the world is cancer-free, that's probably a real misnomer, because a lot of us, they say some people in autopsies, they'll find that people actually had cancers fairly well developed. That wasn't what caused their death. And so how does cancer develop? Well, again, it occurs at the cellular level where your cells just grow uncontrollably. And this is caused by, they talk about the environmental factors, but there really is good information that shows it's genetic, and there's a particular genes that could cause those cells to go awry. And so that's the metastasis is when they go awry. That's kind of the technical term for cancer cells multiplying uncontrollably. And they could spread by your lymph system or your blood system into other parts of the body. And so when you say I got cancer, breast cancer as an example, when those cells go and travel to my brain, just as an example, that's still considered breast cancer, because apparently the cells are the same. They're just relocated someplace else. And the cancer is detected, in particular in my case, it was a routine mammography. All of a sudden I had, stage 3, level 3 breast cancer. But it is detected through, MRIs, ultrasounds, biopsies, etc. And there's several stages, as I said, of breast cancer, which will determine if you're ever in this situation, what treatment you'll get. You can have stage 0, which is basically, it's non-invasive, it's just confined to where it's at. You'll have it go all the way up to grade 4, which is metastasized to, as I say, other organs. There's cell grades that are called 1, 2, and 3. I had level 3 where their cells were growing much faster than they should have. So there's a hormone status that different hormones will in your body. Cancer can be treated with using hormone therapy if you have certain types of hormones that in the cell. Now, I don't want to go into too much detail here because I don't think this, you can certainly read it in the piece, but basically there you could have cell receptors and no receptors, and we don't have any cell receptors for the hormones. That means that hormone therapies, like you may have heard of tamoxifen, they don't work. So you have to opt for, well, usually what they'll say is chemotherapy. Same thing with HER2 status. And as I say, with negatives for the hormones, and the HER2 is called triple negative, okay? So how prevalent is breast cancer? All right, let's talk about that. This is from cancer.net. An estimated 280,000 women will be diagnosed in the United States this year with invasive breast cancer. That's the kind that spreads, already spread. And about 49,000 people will be designated. And it doesn't have to be just women, guys. You think you're out of the woods because, hey, but no, you're not. Men do get breast cancer for far fewer numbers, but you guys aren't out of the woods. All right, so, and then let's see, we have an estimated 41,000 deaths from women and 530 from men from breast cancer. 530 men, as I said, last year died of breast cancer. Think about it that way. Well, on the converse side there, it's about 44,000 women who died of breast cancer. Okay, keep those numbers in mind. Now, how is breast cancer treated? All right, well, there's several approaches depending upon what it is and how far it's spread. You can go for local treatments like surgery, radiations, and other type. Then there what's called the systemic treatments, which include chemotherapy, okay, hormone therapy, immunotherapy, targeted therapy, and each depends on the cancer type. And you can receive chemotherapy either at what they call adjuvant, and that's after you've had surgery or something like that, or you can receive it neoadjuvant, and that's before the surgery to potentially shrink the tumor. And now we're getting the part where I start knowing a lot more than just the kind of the physiological basis. How these drugs work. Some of them damage cancer cells. Some of them block the chemicals the cells need to divide. Some of them, as you well know, just will go in and kill anything that moves. Basically cells that are rapidly dividing, this stuff will kill as well as it will cancer cells. And so, like I say, I'm now on my familiar turf, which is what drugs are used to treat breast cancer, because that's what I studied for 9 years. These divide down what they call alkaline agents, then they do damage to the DNA of the cancer cells. And let's see, we've got cyclophosphamide, cisplatin, and carboplatin. Now, I think you'll find it real interesting. This has been rumored, but I think it's true. Cyclophosphamide was actually made from nerve gas. Comprehend that one. Cisplatin, we talk about anything that says platin in it. That's platinum. It has platinum in it. Okay? They call them platinum drugs sometimes. Next category is the antimetabolites, and they're kind of like antibiotics. Here you have doxorubicin, which is AKA adriamycin. That was the drug that I analyzed for 9 long years. And doxorubicin, interestingly, is called the red devil. And I'm not kidding you here. The red devil. You'll see it in literature called the red devil. It is so toxic that you can't get it on your skin. It'll eat your skin. People have said that you can't, it'll eat like toilets and stuff like that. You can't touch other people if you're on it because your skin will be toxic to them. Okay, so this stuff, I think this is where I started having moral issues with what I was doing. It is so toxic. And it has a cousin there under the anthracyclines called daunorubicin. They've got what mitotic, I think I'm pronouncing it wrong, inhibitors, which inhibit cell division. Immunotherapy is something we're seeing a lot about these days and involves monoclonal antibodies, what they call checkpoint inhibitors. Now you've seen these commercials for like a Keytruda or Ibrance or things like that. These are these immunotherapy drugs, and you'll hear the side effects of them listed real fast. Those people talk fast. It goes over music and stuff, and those things, they may sound, the pitch may sound good, but they're very toxic too. And finally, you have target therapies, where in theory anyway, you can take a drug and target it to the tumor, and it works in that way. That kind of drug, one of them is called an aromatase inhibitor called letrozole. And this is kind of interesting and important. These things will often be given in combination. And what they do is they assign to them acronyms like CMF. C stands for cyclophosphamide, M stands for methotrexate, and F stands for fluorouracil. And they will give all these three together, okay? And there's probably there's probably hundreds of, at least, of chemotherapy drugs. And so you'll find those 3-letter, 4-letter, 5-letter combinations to describe the protocol that they're using. And so, okay, and here's another place. Are these drugs expensive? And it is, I'm trying not to give editorial comment, but I tell you what, you're talking about $150,000 a year for a drug, for an immunotherapy drug, where you have maybe, if you had half a chance of it working, you'd be doing good. $150,000, and then for that one, I called it a monoclonal antibody, it was $50,000 a year. Now, it's interesting dynamic in the pharmaceutical industry, because your off-patent drugs, you have that thing, a patent will try to lock a drug's market exclusivity in for, it used to be just 17 years, and I think they're eking now 30 years out of these market exclusivities. So these drugs, the new ones here, like a Keytruda, might have patent expiration, sometime in 2035. But the ones that were like Adria, like doxorubicin, Splat, and the ones I studied at Adria 40 years ago are now fairly inexpensive because they're off patent. And what you find is that, I was told when I was having the treatment that I said, they don't use the doxorubicin anymore. It's a thing in the past. It's done. You don't have to worry about that. And I said, that's BS. And I came home and looked it up. And so doxorubicin, its annual sales is about, let's see, did I have it on here? Yeah, maybe not on this particular. It's about, I'd say 480 million at least, 480 million to $1 billion a year. So does that say that this drug's not being used anymore? That's the reason they use it. These are cash cows that they offer in some of these regimens. They're older drugs, they're less expensive. I think they're somewhat debatable, but that's why you see them promoted a lot of times. This is marketing, folks, because cancer is a business, all right? So who markets these drugs? Well, guess who? You big pharma. This is why I was emphasized. I said, it's a for-profit industry. I think this is, I'm just going to read it to you. I said, well, they attempt to show the camper drugs, show empathy and compassion in their goals. The goal of any corporation is to increase shareholder value and owner wealth. That is important. These are not charities. These are companies out to make a profit. And so what were the big debilitating side effects? And I just told you a little bit about adriamycin and doxorubicin, but what you want to look for, and in my article, all the drugs I talk about are linked to their FDA, what we used to call them in my day, full disclosures. I think they call them package inserts now. Anytime you might be offered, no matter what the cancer is, you might be offered this drug, go in and pull its full disclosure. It's a package insert off the internet. And this is the FDA. This is what they're allowed to say, thanks to the FDA, that you pull this off and you will read about the side effects. What you want to look for is what they call black box warnings. And it's just what it says it is. It's in a black box. And that's going to be your most dire warnings. And some of these warnings, as I say, they can go from, let me list some of these side effects if I got this here in front of me. cardiomyopathy, that's your heart. In fact, adriamycin, as I was talking about earlier, it has a lifetime limit because it basically destroys heart cells, okay? The hepatotoxicity hits your liver, nephrotoxicity, it affects your kidney. Neutropenia is really important because when we're talking about those immunotherapy drugs, that's the main side effect, is that they whack your immune system and you will have trouble fighting infections and things like that. Other things would include maybe pneumonia, what they call chemo brain, because some of them kill brain cells, and that can last. And then also, I think I was interesting to find out, and I found this in my own data, was causes more cancers. Some of these drugs actually, I've seen people say, you know, I took this drug and now I have cancer. I have cancer worse. So it actually causes cancers instead of treating them. Now, everybody's different. It may work out perfectly for you. You know, you may go sailing through it. So I may just be, you know, saying things that some people find off base. But there is always going to be an element of people for which these are issues. And I think they need to find alternatives. So what's the alternative? Cannabis? Cannabis? Cannabis, anyone? So cannabis, yes, can help with breast cancer. And there's a lot out there about it now. I remember back in the days when you can even say the word cannabis. You can't say the word marijuana, you know? I think Ronald Reagan tried to wipe marijuana research off the face of the earth, you know? They were so against it. And so in several ways, if you're into chemotherapy, then it can help with peripheral neuropathy, as I was talking about. It helps with your inability to eat, you know, the nausea and vomiting and the anorexia that comes with some of those drugs. And, you know, and I think it makes sense considering the human endocannabinoid system. If, you know, I think I feel like I'm talking to the choir, but if I'm not, if there's some legislators here kind of going, well, all of us have a system within us that basically runs on the same chemicals that are in the cannabis plant. The ones that are inside us are called endocannabinoids, and the ones that are in the plants are called phytocannabinoids. Now, maybe it's making this sound too simplistic, and try to not get too technical detailed here. I know a couple of people who are going for their master's degrees who could correct me on all of this. So, so like I say, the endocannabinoid system, since it deals with all, it makes sense why those drugs work. Now, we might remember, going back to 1988, this famous sentence: cannabis was ruled, quote, one of the safest therapeutically active substances known to man. And that was a decision by a judge in 1998, FDA judge. What was his name? I'll get that in a minute. And so we've known it then. And here's the thing. If you guys go to pubmed.gov, remember this, pubmed.gov, go there and put the word cannabis in, okay? You'll find studies going all the way back and reports to, was it 1850, I think it is, the earliest one. You put cannabis and cancer in there, you will find studies, you can find it, you can do it yourself, conducted in 1975 that showed that cannabis, that THC killed cancer cells. 1975, 1976, a couple of written studies about that. And so, and just so you know, there's a trial going on in Great Britain where they're trying to see if Sativex, which is a proprietary THC, it will kill glioblastoma cells, which is the brain cancer cells. And they said, finally, recent surgery over 600 breast cancer patients found 79% using cannabis in some way. And I'd like to also talk about a little bit right now, I don't know how much time I'm having here, RSO. So you probably have heard of RSO. I'm hoping there are some legislators here because I'd like them to talk to them about RSO. RSO is called Rick Simpson Oil, and it comes from a man who developed it a few years back to treat skin cancer. And he put his results on the internet. The internet took off. but he never patented it and he never trade named it. So it's called Rick Simpson Oil, maybe out of honor to him, but there's really no connection to the guy per se, okay? But you can go to dispensaries and you can find Rick Simpson Oil, that they call it that, at dispensaries. And what it essentially is a highly concentrated THC oil. It's in an oil form, and you take it orally. At least I'm going to say that. There's probably people who find other methods of taking it, but orally, that's what you're supposed to do with a protocol anyway. And lab studies have shown that that will stop tumor growth and keep cancer from growing. And so, you know, we're talking about these studies here. And like I say, RSO is, I think, really important. It's a high THC content. So let's keep that in mind. I'll get to that in just a second. And so we've got all this power here. We've got the studies from the past. We've got the studies from Prevalent now showing these great things about cannabis and cancer. So why aren't they out there researching it like crazy? And this is the one thing I'd like to emphasize, if there are any legislators here. One of the main things I'm hearing about those opposed to anything we're doing, whether it's the initiatives or whether it's what I'm proposing here, there hasn't been enough research. Let's talk about why there hasn't been enough research, okay? You know, the research is in the United States is basically handcuffed, I'd say, and that's kind of a kind word actually, because the war on drugs that was instituted in 1971, just purely because the Schedule I stat just put research of anything Schedule I out of hands of any legitimate researcher. You know, there's all I could describe to you the number of hoops that they have to live through between the number of agencies that they have to deal with for clinical trial approval to the acquisition of the product that they use in those trials, and on and on and on and on and on. And so, and you can look at PubMed.gov and chart out the number of research studies by year, and you will see that there's a dip in the 1980s, 90s, even to the early 2000s, because research had just totally stomped out by the federal government. And, you know, any federal funding to go that way, you know, it wasn't going to happen. Okay, so it's basically, in my view, a function of the Controlled Substances Act of 1970 and the war on drugs. And so we're here now, though. Okay, we're here in this space, and we have a chance to render change. Okay, we're the people who do it. If the legislators are here, that's great. Now I'm talking to you guys. You know, we did it in 2016. We did it. I know the program you complain about, but you had to been there in 1982. When people were going to jail, we had in Ohio our own Breonna Taylor, a kid named Clayton Hyrigel, who was shot and killed by a SWAT team in his house in 2008. You know, this is why we're here. We are activists, and we can render change. We know we can do it. We did it before, and we're going to do it again. Now, that's why I'm coming back to cancer here, because in 1971, when Richard Nixon started the war on drugs, he actually declared a war on drugs that we know now that was basically to disenfranchise minorities and hippies. You know, and they had but just months before that, they passed the Controlled Substances Act to enforce that, which put marijuana in Schedule I. And I said you can't do anything with it. That same year, I mean, within months, Richard Nixon declared war on cancer. How do you think he did? Do you think the war on cancer was as successful as the war on drugs? Think it's as successful as the Controlled Substances Act? Think about it. Think about if we hadn't had the war on drugs in beginning 1975. I bet every single one of you knows somebody who died of cancer. I bet you know every one of you knows somebody who died of the side effects from cancer therapies, or maybe was deathly sick. How much death and disease would have been prevented if we hadn't had the Controlled Substances Act and we hadn't had the war on drugs? Let's think about that. So I'm going to leave you with this one thought that heads up my article. If cannabis could cure cancer, would you run for it? And I'm talking to the legislators there. If cannabis could cure cancer, will you run for it? Thanks.